Welcome to the deep dive. Today we're tackling a condition that really is a medical emergency, delirium. Forget the idea that acute confusion is just sort of normal with age or illness. It's not. Delirium is this sudden, severe shift in mental status, and spotting it immediately is critical. Our goal today is to give you a really solid step-by-step framework for managing this.
Yeah, and that framework, it really starts with getting the definition clear. So formally, delirium is defined as a transient, meaning temporary and reversible condition. The key things you look for are an acute change in consciousness and cognition. Specifically, the patient just can't maintain or shift their attention like they normally would.
Okay, and the big picture for you listening, this is mostly seen in older patients, usually over 65, and it is always a red flag. Always. It's never the root problem itself. There's always some underlying trigger causing it. So our mission here is to give you that systematic blueprint, like a shortcut, really, to understand the triage, the diagnosis, and how to quickly hunt down that underlying cause using the mnemonic PNC-me.
Right. So when a patient first comes in, showing signs of acute confusion, before we even think about diagnosis, the absolute first priority is stabilization. We use the standard ABCDE assessment to triage them.
Okay, let's unpack that difference right away. Stable versus unstable. If the patient is clearly unstable, like they can't protect their airway, maybe their circulation is failing, what's the absolute first thing we do? No messing around.
You jump straight into immediate stabilization, no question. That means securing new airway, making sure breathing is adequate, checking circulation, getting IV access, giving supplemental oxygen. You want that saturation above 90% and starting continuous monitoring. Heart rate, BP, O2 sat. If they're unstable, diagnosing the delirium has to wait. Patient safety first, always.
Got it. Okay, so once we know the patient is stable, then we move to the focused history and physical exam. And often, like you said, they might present with sudden hallucinations, or maybe the family says they're just acting really unusually.
Yeah, and key to the diagnosis is noticing the fluctuation. This is crucial. The changes you see must be an acute departure from their known baseline mental state. And it has to follow this fluctuating course. People often describe it as waxing and waning through the day. If the change isn't sudden or it isn't fluctuating, probably not delirium.
Right, that makes sense. And this fluctuation is key because delirium actually shows up in 3 different ways, doesn't it? There's the one everyone kind of pictures, hyperactive delirium. That's the agitated, restless, maybe even combative patient.
Exactly, but then there's the one that often gets missed, hypoactive delirium. These patients, they're drowsy, quiet, withdrawn, seem apathetic. Maybe they barely speak. They just look really tired or maybe even depressed.
Okay, so if the hypoactive type is the one that's often missed, is that where the biggest clinical risk lies? Is that the one we should be most vigilant about not overlooking?
Absolutely. That is probably the critical insight here. Hyperactive delirium often gets brushed off as just fatigue or maybe sedation side effects, but clinically, it's actually associated with higher mortality rates and worse outcomes, precisely because it's easily missed. It doesn't cause a fuss, so the underlying trigger might smolder unidentified for longer.
Wow, okay, that's really important. And then the third type.
That's the mixed type. They switch back and forth, maybe agitated and restless in the morning, then quiet and sleeping all afternoon. That variability is the hallmark.
Got it. So assessment, checking stability, looking for that acute fluctuating change, and knowing the 3 types. What's next?
Well, here's another really critical point. Delirium is fundamentally a diagnosis of exclusion. There's no single blood test, no scan that says, yep, it's delirium. So before we actually confirm delirium, we absolutely must rule out other conditions that can look like it.
Right. So the biggest mistake would be, what, jumping to treat the agitation without ruling out something like a stroke first. That means really looking for things like slurred speech, any new weakness, especially on one side, or trouble speaking clearly, like hemiparesis or expressive aphasia.
Precisely. If you see those kinds of focal neurological signs, your alarm bell should be ringing for an acute brain event, like a stroke or bleed. Your focus immediately shifts there. That's a neurologic emergency. But if you've ruled those out, then we use a validated tool to confirm our suspicion of delirium. That tool is the confusion assessment method, or CAM.
Okay, the CAM. And this confirms it based on specific features.
Yes, 4 features. You need the first 2 plus either the third or the fourth. So feature 1, that acute onset and fluctuating course we keep talking about, has to be there. Feature 2, inattention, they struggle to focus, also have to be present. Then feature 3, disorganized thinking, their thoughts are illogical, unclear. Or feature 4, altered level of consciousness. So anything other than alert, hyper-alert, lethargic, stuporous, even comatose. You need 1 and 2 plus either 3 or 4.
Okay, so acute fluctuating, plus inattention, and then either disorganized thinking or altered consciousness.
Exactly. If you meet those criteria, you have a CAM-positive diagnosis.
Yeah.
And now the urgency really ramps up. The clock is definitely ticking to find that root cause. But first, immediate safety.
Right. So CAM positive, delirium confirmed. Next step. Risk stratification. Basically, is this patient likely to harm themselves or others? How does that split our approach?
It splits it quite significantly. For patients who are low risk, and these are generally the hypoactive ones, we focus almost entirely on non-pharmacologic management. We look really closely at their medications. Can we reduce or stop anything known to have CNS side effects? Things like opioids, benzodiazepines, certain anticholinergics. We'll get them moving frequently. Mobilization is key.
And focusing on the environment too, right?
Yeah.
Simple things like making sure there's a clock and a calendar visible, getting them their glasses and hearing aids to cut down on sensory deprivation, promoting good sleep, good hydration, nutrition.
Absolutely. All those non-drug interventions are the first line, especially for low-risk patients. But for the high-risk patients, usually the hyperactive ones, maybe they're trying to pull out IV lines or climb out of bed, fighting staff, we still start with those non-pharmacologic methods. Redirection, trying to de-escalate verbally, maybe increasing staffing, like assigning a sitter.
Okay, but if those behavioral approaches just aren't cutting it and the patient is still a danger, then we have to think about medication. The sources seem to point towards haloperidol or maybe a second-generation antipsychotic like olanzapine. And haloperidol often gets picked because it's less likely to cause heavy sedation or low blood pressure.
That's generally true, but it comes with a really critical warning. This is vital for everyone to understand. Haloperidol is strictly contraindicated, meaning absolutely should not be used in people with certain heart conditions, specifically a prolonged QT interval.
Okay, why does that matter so much? Can you break down what a prolonged QT means in practical terms for us?
Sure. A prolonged QT interval means the heart's electrical system is taking too long to sort of recharge between beats. This significantly increases the risk of a specific, potentially fatal heart rhythm problem called torsades de pointe. So, if a patient has a known history of prolonged QT, or risk factors for it, haloperidol could be very dangerous. Also, it's contraindicated in patients with Parkinson's disease or Lewy body dementia.
Why those conditions specifically?
Because haloperidol blocks dopamine receptors, and in Parkinson's and Lewy body dementia, dopamine pathways are already compromised. Giving haloperidol can drastically worsen their motor symptoms, rigidity, tremor, slowness. It can cause significant problems.
That makes the warnings much clearer. So use with caution, check the EKG, check the history. Okay, so we've managed the immediate risk. We've secured their safety using non-pharm or carefully chosen pharm interventions. Now we have to find the trigger. That's the main event. And we start with some basic labs, right? A CBC complete blood count and a CMP comprehensive metabolic panel.
Exactly. Those initial labs are crucial as we launch into our systematic search using the PINCY-HME mnemonic. PINCY-HME is like our checklist, our safety net in the chaos to make sure we don't miss the common fixable causes.
All right, let's dive into it. P is for pain. And this isn't just about someone saying, ouch, after surgery, is it? It can be much quieter, especially in those hypoactive patients.
Absolutely. You really have to actively look for those nonverbal signs. Are they grimacing, clenching their jaw? Are they moaning, even quietly, guarding a part of their body? Even in patients who aren't speaking much, pain can be the driver. If you suspect uncontrolled pain, the action is straightforward but vital. Optimize their pain control. Adjust doses, maybe switch medications.
Okay, P is pain. Next, IN stands for infection. The history might give clues here, right? Fever, chills, maybe a cough suggesting pneumonia, or painful urination suggesting a UTI?
Yeah, the history helps target your exam. Listen to their lungs. Check for any tenderness over the bladder area, the suprapubic region, and those labs we ordered. The CBC might show leukocytosis, that's a high white blood cell count, a sign of infection. If you suspect a UTI based on symptoms or a quick urinalysis showing white cells, nitrites, or leukocyte esterase, get a urine culture. If you suspect pneumonia from a cough and abnormal lung sounds, get a chest x-ray, maybe a sputum culture. And the key action, start appropriate antibiotics quickly based on the likely source.
Makes sense. Moving on to C, constipation or urinary retention, I think this one surprises people. It seems almost too simple that being backed up either way can cause such severe confusion.
It is surprisingly common, especially in older adults, maybe less mobile patients, or those on certain medications. History might reveal they haven't had a bowel movement in days, or maybe they're having frequent small voids, suggesting retention. Look out for a history of BPH, benign prostatic hyperplasia, or enlarged prostate in men. And always check the medication list for drugs known to cause constipation or retention, like opioids or anticholinergics.
So the action here is pretty direct, too. Review the meds, maybe stop or change one, start a good bowel regimen, laxatives, stool softeners, or if you suspect urinary retention, maybe an ultrasound of the bladder, or even placing a catheter might be needed. Get things flowing again.
Exactly. Get things moving. Next is H, hydration and electrolytes. Dehydration can often be picked up on exam, dry mouth, dry mucous membranes, maybe poor skin turgor, though that's less reliable in older adults. The CMP we ordered is absolutely essential here. We're looking for electrolyte imbalances.
Right. Things like sodium or calcium being either way too low or way too high can definitely trigger delirium. So the action is clear. If they're dehydrated, give fluids. If there's an electrolyte imbalance, correct it carefully based on the lab results.
Precisely. Optimize hydration, correct the numbers.
Okay.
Next up is M, medications or substances. This one's a bit broader, covering 3 distinct scenarios.
Okay, 3 scenarios under M. What's the first?
First is intoxication. This is acute, recent use of a substance. Alcohol, illicit drugs, even some prescribed meds taken in excess. You might get confirmation from serum alcohol levels or a urine toxicology screen. Management here is generally supportive care, monitoring them closely while the substance clears.
Okay, intoxication. What's the second scenario?
Second is withdrawal. This applies to people who use a substance regularly long-term, but have suddenly stopped or cut back. Think alcohol withdrawal, benzodiazepine withdrawal. They might present with high heart rate, high blood pressure, sweating, tremors. But crucially, their tox screens might be negative because they haven't used recently. Management of supportive care, close monitoring, and in severe cases like delirium tremens from alcohol withdrawal, they might need benzodiazepines to manage symptoms safely.
Got it. So negative screen, but signs of withdrawal. Need to consider that history. And the third M.
Third, and probably the most common in hospitalized patients, is medication-induced delirium. This is delirium caused by the intended therapeutic use of a medication that just happens to have CNS side effects. We always suspect drugs like opioids, benzodiazepines, anticholinergics, sometimes steroids, even certain antibiotics. The action here is critical. Identify the likely offending drug. Can you stop it? Can you reduce the dose? Can you switch to a safer alternative?
Makes sense. Reviewing that medication list seems vital at multiple points here. Okay, last letter, E for environmental triggers.
Right. These are factors related to the patient's surroundings and routine. Being in an unfamiliar, stressful environment like the ICU, sensory overload or deprivation, noise, constant interruptions, poor lighting cues, recent major surgery, the lingering effects of anesthesia or heavy sedation also fall under this.
So the action for E is all about trying to normalize their environment as much as possible.
Exactly. It's about reestablishing a normal circadian rhythm and reducing stress. Try to reduce noise, especially at night. Maximize natural light during the day. Keep it dark and quiet at night. Minimize interruptions, especially during sleep periods. Promote mobility if possible. Orient them frequently.
Okay, that covers PIN-CH-ME, pain, infection, constipation, retention, hydration, electrolytes, medication substances, and environment. Before we wrap up the causes, you mentioned one last specific lab finding to keep in mind.
Yes, just a quick but important point related back to those initial labs, specifically the CMP. Remember azotemia. This basically means a buildup of nitrogenous waste products like BUN, blood urea nitrogen, and creatinine in the blood. It's usually a sign of acute kidney injury, or AKI. This buildup of toxins directly affects brain function and can absolutely cause delirium. So always check that BUN and creatinine. Look for signs like low urine output. And consider if the patient has been exposed to kidney-harming drugs, like high-dose NSAIDs.
Okay, got it. Azotemia from AKI is another potential metabolic cause reflected in those labs. #outro. Wow, that really is a complete picture. We've walked through the entire systematic approach, starting with that initial triage ABCDE, then confirming the diagnosis by excluding mimics and using the CAM criteria, managing the immediate safety risks non-pharmacologically first, then pharmacologically if needed, but carefully. And finally, that crucial systematic hunt for the reversible cause using PIN-CHME, pain, infection, constipation, hydration, meds, environment, and watching those kidney labs.
Exactly. And the whole point, the ultimate goal, once you find that underlying cause, whether it's the infection, the pain, the dehydration, the medication, once you address and treat that, you have to monitor the patient. Keep monitoring them until they definitively return to their baseline mental status. Provide supportive care throughout. Delirium can be terrifying for patients, families, and staff, but remembering that it's often reversible if we find and fix the trigger. That's empowering.
Absolutely. And that actually leads perfectly into our final provocative thought for you, the listener, to think about. Given that the goal is returning the patient to their baseline and knowing how much environmental factors, sensory issues, noise, sleep disruption can trigger delirium, we've mostly talked about the hospital setting, but what about outside the hospital? For someone who might be at higher risk, maybe elderly, maybe with some cognitive decline already, what kind of changes could be made in their daily life at home? Things related to maybe reducing sensory deprivation, ensuring good daytime light exposure, better sleep hygiene. Could these act as preventative measures before they ever get sick enough to need acute care? Something to mull over until the next time we deep dive into the source material.